Okay, morning everybody. Thanks for coming to this massive, great institution in such a great location in central London. Such nice weather, and I'm told the Queen's coming this afternoon, literally coming this afternoon. For us, perhaps not. She's got something at Westminster Abbey, is that right? Sorry, you were telling me. Anyway, this is the plenary session, main part of the meeting, if you like, and it's going to be a congenital theme to celebrate the great work that's been done for many years in the UK in congenital cardiac surgery, especially now, the way you can see things. And we've got a number of speakers who are going to show that, I'm sure, this morning. First of all, though, we've got a talk from Eric Lim. So, Eric, do you want to come to the podium? We've swapped the order around from what you've seen in the programme. Eric's going to talk about the Violet trial, which is a thoracic surgical trial, for a few minutes, and then we'll move on to the congenital section. Thank you, Eric.
Thank you very much. Thank you for the opportunity to speak in this plenary session. 10 years ago, the thoracic surgery research community sat down and started thinking seriously about thoracic surgery research. We wanted to be in a position to be able to apply for hard-hitting, grant-funding, surgeon-led clinical trials, translational research, and also to support such infrastructure in the United Kingdom. This led to the development of our first randomized controlled trial, which is Violet, a trial about keyhole versus open surgery that took part in 9 centers across the United Kingdom in 2 waves. The first wave of 5 centers and the second wave consisting of 4 surgical centers. Across the United Kingdom, screening over 2,000 patients to be able to recruit 500 patients over 4 years to this study. If you were a surgeon taking part in Violet, could I please ask you to stand up? And if you are a research nurse or part of the team, could I please ask you to stand up? If you were a surgical colleague diverting your patient's flow to help recruit into Violet, could I ask you to please stand up? If you supported the trial steering committee or data monitoring committee, can you please stand up? If you were involved in taking care of the Violet patients during the operation, maintaining the blinding after the operation, following up in clinic, could I please ask you to stand up? Because, ladies and gentlemen, the people standing up before you have made history in that they're responsible for delivering the first multi-million NIHR-funded clinical trial in thoracic surgery in the United Kingdom. This Violet has become one of the biggest recruiting trials in the history of thoracic surgery worldwide. But they did not do it to time. They did it 2 months ahead of schedule. Resulting in an accrual graph that has rarely been appreciated in the history of the NIHR. And I'll leave you some quotes at the end so that you have an NIHR view of what they thought about this trial. I promised the President to present some results of the Violet trial, not the primary outcome, but I'd like to, this slide for me creates the most interest. It shows that approximately half of the patients in the United Kingdom enter the operating theater without a tissue-confirmed diagnosis of lung cancer. And through a combination of clinical acumen and or intraoperative frozen section biopsy, it led to 1.4% benign resection rates, which is half the benign resection rates achieved by other countries worldwide in similar trials. This represents real-world data because 0% I don't think is achievable. And it just is a testament on the quality of the thoracic surgeons in the United Kingdom. People have asked what's happening after Violet, and the simple answer is that we still have a lot of fuel in our tanks, and we will continue completing our translational research, which explores the redefinition of residual disease from a molecular perspective and through the patient's blood, which is a $750,000 industry grant-funded study. But all of this, in essence, is just a warm-up, because the biggest challenge in thoracic surgery at the moment is immuno-oncology, with the startling advances and improvements to prolong survival, it is imperative that we are in a position to be able to evaluate if there is a role in the patient pathway within the immuno-oncology era for advanced lung cancer. In all, I think that we have come an extremely long way, and there's still lots more to be achieved on our first surgical-led translational research trial, and the ability to evaluate our position by widening the indications for thoracic surgery into advanced lung cancer. People have consistently asked me from a technical standpoint of view, which aspect of the qualitative recruitment or what methodology have you imputed to attain such successful recruitment into Violet? But I can honestly say to you that it has been an immense pleasure to work with the Violet team, and one of the most important aspects of why it is successful is because fundamentally we are friends. So I would like to thank all of you and also all my friends for the honor and privilege, for your support and trust in me to take Violet to completion. Thank you so much.
I'd like to invite our first speaker to this plenary session, Jo Quirk, who is currently a lead nurse for the Yorkshire and Humber Congenital Heart Disease Network, working to promote the NHS Standards for Congenital Heart Disease 2016 and assisting in developing services throughout the network of 18 hospitals. Jo has previously worked as a nurse specialist for adult congenital and paediatric cardiology at Leeds General Infirmary. Good morning, Jo, and you're very welcome to the Society annual meeting.
Thank you very much, and good morning, and thank you for asking me to talk today. So, as Helen's explained, I'm going to talk to you today about transition from paediatric to adult services. So just to start with, we need to just think a little bit about what healthcare transition is. And it's about empowering and supporting children and young people and moving them over to the adult-orientated service. This process addresses both the medical, psychosocial and vocational needs of young people. So to start with, just a little bit about the developmental tasks of adolescence. And it is about moving the dependent child to the independent, resilient, autonomous adult. And hopefully, this is Adele, and hopefully this won't be what they'll be moving into with the smoking. A little bit about sort of normal adolescence. So there are 3 stages, and we define them as early, middle, and late adolescence. So the early adolescence is about the physical changes. Middle adolescence is about where peer groups play an increasing part in the identity and separateness from parents. And late adolescence is about relationships and closeness. And these normal individual and family developmental processes are greatly influenced by the context of chronic illness. So why do adolescents differ? Well, they differ in the way they behave, the way they solve problems, and there's actually a biological explanation for the difference. The main developments are within the brain, and it's said that adolescents are working with brains that are under construction, so they are very different to children and the adolescents moving on. And this is a diagram that talks a little bit about why the average teenage brain is different. And the large section at the front is all about emotions, relationships, and I think that's probably why they all watch Love Island and all the stuff on the television. And right down at the bottom, there's a tiny little yellow memory for chores and housework, and probably a lot of us can relate to that if we've got teenagers ourselves. So what do young people want? What do they want from services that we can offer? Well, there's quite a lot of research that has been done about what young people want, and they want to be listened to, and they want to be talked to themselves and not to the parents. They want to be treated as an individual, and they want information that they can understand. So why is it important that we provide a transition service for congenital heart disease? And what's happened with the developments in the specialty? And I'm going to talk to you a little bit today about the team approach. So over the years, many paediatric patients with congenital heart disease were actually discharged a good few years ago from active follow-up because they're thought to be fixed after surgery. And we know now that there is very much an importance of ongoing surveillance. And lots of patients who've been lost to follow-up over the years are now being referred to the service in their 20s, 30s and 40s with complications due to their sort of surgery they had in childhood. Because of that, we now know we have an established adult congenital heart disease service. And this is a specialty seen in its own right. It's not a bolt-on to paediatrics. It's not a bolt-on to acquired heart disease. It is a specialty with consultants and nurses who have been trained in adult congenital heart disease. We know that adolescents are different to older children and adults. And obviously, there's lots of medical and surgical advances in the specialty. And that's been recognised by the NHS Standards 2016, as there's the whole section. And from our perspective in congenital heart disease, that's a big part of what we are working towards and living and breathing the NHS standards at the moment. So who are our patients in transition? Well, our patients now that are moving into the transition service are patients following arterial switch. We previously saw the mustard and Sennings patients, and now they're the ones that have had the arterial switch. Those that have had repaired AVSDs, ventricular septal defects, the repaired coarcts, aortic valve disease, and those with inherited cardiac conditions such as Marfan's. But the most sort of important complex ones that are moving through to transition that we are spending a lot of time and energy and support with are those with hyperplastic left heart syndrome, those with complex single ventricles that are now moving into our adult service. And we must remember that 10% of ours have learning disability, trisomy 21, 22q11 deletion. So why is it important that we provide a transition service for our patients? Well, it's about us assisting young people to living life to the full. And it's making sure we provide age-specific and developmentally specific information for them to make life choices. We need to educate them about any limitations and issues related to their condition, and there may not be any, but they need to know that when they come to the clinics. To provide support as appropriate, and very importantly, we need to reduce loss to follow-up rates, which we know reduces mortality and morbidity. So what are the issues for our young people? From a medical perspective, it's important that we give them appropriate information that's jargon-free, with an opportunity that they can be seen independently from their parents. Patients from the age of 16 can sign their own consent, and it's important that they have that opportunity to be seen in the right environment. We mentioned earlier that 10% have a learning disability, so capacity assessment's really important, and we need to ensure that everybody is involved as to whether they can sign their own consent. From a lifestyle perspective, in clinic, these are some of the issues that we would talk to young people about. What are their career options? Have they been given enough information about pregnancy risk and contraception advice? Lots of questions about theme parks. Can they go on the roller coasters? What about endocarditis risk? Can they have piercings, tattoos? And we need to know that young people do come with parents, and often parents can be overprotective, understandably. But it's about working with parents as well and encouraging them to sort of let go. So what happens in Leeds and Yorkshire and the Humber network? Well, over the years, we've developed the service in Leeds, and we've tweaked the service in order to include the multidisciplinary team. And the last sort of 12 to 18 months, we have a youth worker now that works alongside us to help us address some of the issues for our young people. We know that transition is everybody's business. It starts at the age of 12 years. It goes through to early adulthood. And it's important that everybody is signed up to transition service. And this includes cardiologists, nurse specialists, and people that have the exposure to our patients. At Leeds, we're lucky that we've got paediatric and adult services all on one site, and this includes maternity services, because we do know that 14-year-olds can get pregnant, and that allows our obstetric and cardiology teams to work together and support the patients. Over the years, we've offered transition evenings, and that's where we invite young people at the age of 14, 15, to come in a sort of a more relaxed atmosphere to the hospital, so they get an opportunity to introduce ourselves to the adult services and reduce anxiety about moving across to adults. There was quite poor uptake over the years, and we've tweaked the service, and now we offer free pizza and Wi-Fi, which suddenly we find that we get lots more people attending. And we've made some changes to our service and changes to our communication strategy, which includes social media. This is a busy slide, and it just really just explains a little bit about the pathway, and it's adopted from the Ready, Steady, Go work that Southampton Hospital started a few years ago, and just explains a little bit about how the service starts at the age of 11 to 12 years and right through up to sort of early adulthood in their 20s. So I'm going to just talk to you a little bit now about a case study, Isabelle. She was born in 1996, and she had a diagnosis of a large VSD and tricuspid atresia. She had a right Blaylock shunt as a baby, and then moved, when she was 5, had a Fontan with fenestration in August 2001. She was very well throughout childhood. She was seen annually in the paediatric clinics. Parents were both professional. She had 2 siblings, and at the age of 16, moved to the adult congenital service. Unfortunately, that's when her sort of problems started. So when she was 16, she started with pericarditis and required admission for that. Following year, she had an episode of atrial fibrillation. She required cardioversion and had a further episode of pericarditis. She continued with her atrial arrhythmias, had cardioversions, intolerance of flecainide, and then continued to have 2 atrial ablations, and in 2017 a stent to a left pulmonary artery. And at the age of 22, she had a Fontan conversion due to a troublesome atrial arrhythmias at Newcastle. Despite that, she tried to be very independent. She went on holiday with a boyfriend's family at the age of 16. She did her A-levels, applied to university, went to do dentistry and was accepted into dentistry. And she started university, and I just picked out this quote from one of the letters that the cardiologist wrote, that she did mention going to university has probably resulted in a greater realisation for her that she has a fairly significant underlying cardiac condition, and this will limit her abilities compared to her friends. She went to Rhodes, but unfortunately went into AF, and we had to arrange a cardioversion while she was on holiday. And she did take out a year at university due to having her surgery at Newcastle. number of discussions about pregnancy risk in clinic. So how have the team helped her with her? So as she was on anticoagulation, we provided her with a home test machine for her to monitor her bloods at home, and this allowed her to have her independence. She could do her bloods at home, or whether she was at university, and ring through to the clinic for advice. When she started with her arrhythmias, we got her an AliveCore device, and this is a small device, handheld device that clips on the back of your smartphone, and they can monitor the arrhythmias, send the results through to the team, and then we could advise her. She was given information about her condition, managing her symptoms, travel insurance, contraception, and we referred her to the psychology team for counselling. Most recently, we spoke to the dean at the university because they had concerns about her ability to complete the course. So we wrote some letters, we spoke to the dean, and we were successful in the fact that she's now started year 4 of a dentistry course. And I think this just gives an example of what the treatment goals are for the medical team versus hopes and dreams for these young people, and trying to get that balance really to achieve that. I'm glad to say that not all the transition cases are so complicated. Many patients come to the outpatients every 1 to 2 years, and it gives us the opportunity for us to give appropriate information and lifestyle advice. We need to remain flexible to meet their unique needs, and we provide support and services between appointments, which most are available online via the charities. We've got Leeds Congenital Heart website, and we've got a Facebook account. Because actually we need to look after these patients, keep them healthy, as actually some of them may be coming your way. Thank you very much.
Thank you, Joe. We're going to have the next speaker, and then we'll have an opportunity for some questions. I think this morning at the congenital sessions, Professor David Anderson gave us an inspiring talk reflecting on 40 years of working in congenital heart surgery in this country. And I think one of his final slides, one of the messages was that the good physician treats the disease, the great physician treats the patient who has the disease. And I think it's useful to stop and think about that on a day like today, when we're looking at what's been achieved over the last 40, 50 years in our profession. And sometimes at these meetings we focus too much on the operations and the technicalities and don't think about the patients who are behind it. So we're very lucky this morning to have Adrian Chester coming to speak to us. Adrian is an extraordinary man. He's a very successful cardiovascular scientist, but he was also born with congenital heart disease. And he can share with us some of the impact of living through our eyes in our profession, with the impact of living with congenital heart disease and some of the successes and failures and how that's impacted on his life. So thank you, Adrian.
Thank you very much. And thank you for the opportunity to come here today and share with you my experiences. So this is a picture of me almost exactly 5 years ago. And I remember it because it was my 49th birthday. And I was about to enjoy a very nice meal, and I had a very happy and memorable day. And I had a lot to be happy about. And if I look back at what I achieved in my life, I can claim to have led a fairly ordinary and pretty average life. I went to school, university, I've held down a full-time job, got married, a mortgage, I even got a PhD, and have a son and a daughter. But against this, all this was achieved against the backdrop of living with congenital heart disease. So a brief description of my sort of medical history up until 2010, where my mother noticed I wasn't feeding very well at the age of 10 compared to my elder siblings, and took me to the local clinic. So this is something akin to the program called The Midwife. I mean, this is in the 1960s, 1965. Fortunately, I wasn't brought up in the East End. I was brought up in leafy Richmond. But the same level of care and ability to diagnose cardiac conditions existed. So it took some time before I was diagnosed with having tricuspid atresia. And in 1974, I had a modified Fontan operation. And essentially remained particularly well throughout my adolescent time, and can't really claim to have any particular difficulties in that time. But there was no transition, as we've heard. There was no adult congenital heart disease in the 1970s and 80s. And later on in the 80s, I began to have symptoms of tachycardias, which ultimately ended up in an ablation procedure in the year 2000, which, although claimed wasn't successful, did stop my tachycardias for 10 years, probably due to change in my drug therapy. But I did have a rather nasty bleed and spent probably 2 weeks in hospital trying to recover from that. But other than that, I was able to conduct my otherwise normal life. But I want to show how my attitudes changed about myself and my disease over the course of my life. So if you're interested in the operation I had, it was written up and published in this paper by the then Mr. Yakub, but now, of course, Sir Professor Yakub, and Rosemary Radley Smith, who were a lot younger in those days, and they didn't look like that. So here I am, probably at the age of 5, about to go to my aunt's wedding. And at that age, I was, or my childhood, let's say, I was aware I was different either to my brothers and sister and to other children at school. And I knew allowances were made for me at primary school. But that didn't really make me feel particularly comfortable. Being allowed to stay in when it was cold sounded like a good idea, but I was the only one inside. Everyone else was outside. In those days, you wore short trousers to school, whatever the weather was at primary school, but I was told I could wear long trousers. That didn't really help either. It just made you look different. But I remember when I went into hospital at the age of 9, and I was told I wasn't going to go to school from the May half term until the following September. It sounded like a good deal to me. But I have very vivid memories of the time I spent in hospital, probably the most vivid memories of my whole childhood. And having certain drinks at certain times brings back those memories. I can remember the children who I was in hospital with, who strangely I didn't then seem to see again. And I can remember the sound of a woman crying uncontrollably. And all those things, you know, it's like they happened yesterday in some respects. But my hospital visits and my outpatient times was essentially a time I could spend with my parents just by myself. I had a family of 4 children, and it was unusual to have the sole attention of either of your parents, or both of them, particularly my dad. You know, he was out to work. My mum was a stay-at-home mum or a part-time nurse. And it was a different time, and it was something we did, and it didn't really seem a chore or something bad. I was well, but it got awkward when I got a bit older in my teenage years and was marched off back to see the nurses on the ward. My mum was keen to do that, but all the children there were much younger than I was, and you do begin to feel awkward, and I can identify with the problems teenagers would be having during their transition phases. So in terms of my siblings, I think it was a blessing in disguise. We were a relatively large family, and all our ages are very close together. And our parents made sure we sort of did everything together. And I was never made to feel left out, neither was a fuss made of me. I just got along with the rest of them. But, you know, subconsciously or consciously, you know, I was accommodated within the limitations of what I could do. But essentially, particularly at secondary school, I developed my own interests, not because I was limited in what I could do physically, but just that's what I ended up doing. So I took up fishing, for example, and enjoyed that, and had a crowd of friends, and that's what we did. I can remember my dad being keen on marching over every hill that he could find when we ever went on holiday in the UK, and my brothers and sister would go, and I would stay with my mum. And I remember that feeling a bit left out, but that was probably the only time I ever really felt like that. In terms of physical activity, it's something I enjoyed. I enjoyed PE, but never did swimming lessons, for example. I remember at primary school going to watch everyone else go swimming, and I was sat on the side with the person who had a cold or a verruca, but I never went in. I enjoyed PE at school, but found that actually my condition had one good advantage. The day the cat peed in my PE kit, I had a get-out-of-jail card to say I didn't really feel like PE today, and saved me running around the field in my underwear, which was commonplace in schools in 1970s. Not really a good way to treat children. But the one sport I did like, and something my dad did and my brothers did, was play cricket. And you can see me here, the captain of this particular cricket team. If you're not a particularly good picture, but you'll be able to spot my two brothers, who I played with, one next to me and one in the far top right-hand corner. And it was a game that if someone wants to play sport who has congenital heart disease, is entirely suited, because it's a stop-start game. You can, as I did, hide in the slips, not do much running around. I had the technical ability to play cricket. There's not really the cardiovascular system to, score 100 or a 50, but it was something I enjoyed, and I enjoyed the social scene. But essentially, by the time I got to my early 20s, middle 20s, I can blame it on the lifestyle change. I moved away from home, I got a girlfriend, etc. But really, I found it a bit too much. And at the end of the games, I was really, really tired and not keen on taking part on the more enjoyable social side of things. But, I managed to do it, and I enjoyed my time playing cricket. So really, the stage of my life where I could say everything changed was when I coincidentally got a job working for Professor Yacoub in research. So my initial first case of tachycardias, I was admitted to West Middlesex Hospital, spent a week there on a cardiac care unit with people who had heart attacks, felt completely out of place. But it put me back in touch with Harefield, and then because of the job I had got after graduating, working for Glaxo doing research, Professor Yacoub then offered me a chance to do a PhD, and I've then worked at Harefield ever since. Probably the best decision of my life. Because there I met my wife, but not just that, I was able to then access hospital care when I needed it, when I had tachycardias, etc. So I forego the presenting at casualty, meeting doctors who didn't understand my condition, and spending more time, as I had done the first time it occurred, in a cardiac care unit or on an adult ward with people not really understanding what my particular problems were. But the other thing that I then found out was really how severe my condition was. Working in close proximity with other medical people, I realised what a Fontan circulation really meant, and I would come across papers about Fontan circulation. I would have a look at them, look at the survival curves, and realise I wasn't on that curve because my survival was so much longer than many of the studies that were actually published, which you think is good, and then you think is, well, what's going to happen to me? Where do I sit in with this whole picture? The other thing that changed was, of course, I had children. And of course, when you have children, you suddenly realise what it's like for your parents when you were younger, and you have all the concerns about your own children. And fortunately, my two children are perfectly healthy and active, and I realised what it must have been like for my parents to have such a sick child. And then trying to cope with that, and also how to handle telling your children about your condition. So the first ablation I had, where I had the bleed and ended up in hospital for 2 weeks, we initially told that my then 6- and 4-year-old that I was going away to a meeting. And of course, when I didn't reappear, they were concerned, and you could tell that they knew something was wrong. So I made a conscious decision, which was the right thing to do with the benefit of hindsight, was to try to inform them about the fact that Daddy wasn't as well as everybody else, and he had a certain condition. And as they got older, they naturally wanted to know more things, and I was happy to tell them. I felt it was unfair to hide it from them. But my sort of married life and my sort of greater awareness of what was wrong with me then actually made me feel like a bit of a time bomb. I had a lot of people then depending on me, my children, my wife, realising what my condition really meant, my wider family. And I did feel like a bit of a time bomb waiting to explode, and really thinking the impact of a decline in my health might have on people. But despite that, I resolutely was determined to continue as normal, and as I used to say, make hay while the sun shines. I knew things might change, but didn't really think about it, refused to think about it, and just focused on the here and now. And, you know, successfully worked in cardiovascular research, been to many, many meetings, travelled the world, published papers, and had a very happy life. But then, as time went on, a lot of the things I took for granted began to be beyond me. So if I look across my sort of 20s, 30s and 40s, and I sort of made this chart and thought, well, what are the things I used to be able to do that I can't do now? And slowly but surely, they all started to become crosses instead of ticks. And this really coincided with a decline in my health from about the age of 45 onwards. Nothing sudden, but when you look back at it, there was just a general slippery slope that slowly got quicker and quicker. Mainly involving volume overload, admission to the Brompton. I was then cared for by the adult congenital unit at the Brompton Hospital. I had the valves that had been placed in my IVC and my pulmonary conduit stented. That was hoped to improve the arrhythmias that had returned, although in fact they returned almost worse than before and more aggressive. I had a number of ablation procedures. I ended up with very high venous pressure, had terrible varicose veins, which on occasions burst with almost catastrophic, well, it looked catastrophic, the amount of blood that would come out. Would have to go immediately to casualty, normally to have my villix stitched. I ended up with leg ulcers, and then eventually ended up having hemoptysis and coughing up blood, which I found particularly unpleasant and concerning. And I developed terrible ascites and essentially looked like a pregnant man. So, of course, the word transplantation kept being mentioned throughout this catalogue of events until such time that it was obviously spelled out to me that there was a correct time as a Fontans patient to be transplanted, and that wasn't until you felt really, really ill. And I essentially had to make the decision of what was the best course for me to take. But it was made slightly more difficult by the consideration that while I lived in Watford, obviously in the southeast of England, I was advised to go to the Freeman Hospital in Newcastle, so I'm approximately 260 odd miles away from home. My nearest relative was my brother, who lived in Liverpool, and this was a big decision to make in terms of logistically how would we cope, and how would I cope in terms of being so far away from home for so long. And you know, there were lots of things to take into account, but I knew from a medical point of view that it was the right thing to do, to go to somewhere that had the experience of operating on someone like myself, which Newcastle did, considering, you know, everyone who knew I was going to Newcastle said, well, why don't you have it done at Harefield? It's down the road. So it seemed an illogical decision to people who weren't informed, but I knew it was the right thing to do. And I knew that I wanted to improve the quality of my life. I knew it was the right decision for me, and I knew that even if it went wrong, it was still the right thing to do. And I think it was a tough thing, but we made the decision as a family. And in fact, it was my son who ended up coming up with the clearest thing about when to do it. He said, look, you're not well, just get on with it, and then, you know, we'll carry on as we were after you've done it. But they all knew the dangers. And I think being open with my children at a young age helped them cope with what actually then transpired to happen. So a brief run through of being admitted to Brompton and then transferred to the Freeman for assessment for a heart transplant. But once there, they realised that all the ascites I had wasn't really from my high venous pressure, but more linked to my liver. And essentially then I went back for assessment for a liver transplant and was accepted for a combined heart and liver. So while I was in the Freeman for the liver assessment, the ascites I had started to leak from my navel, which they didn't like the look of at all. So they immediately drained it. So they removed 14 litres of fluid. And this sort of changed my mind temporarily, because this massive bulge I'd been carrying around was gone in a matter of hours. And I thought, well, perhaps if so I went home with the intention of going to my daughter's 18th birthday party. And I thought, well, if I go home and all this fluid's gone, perhaps if I, you know, don't drink too much and I do everything the doctors say, perhaps I'll be all right. And I sort of thought this. So I went home, went to my daughter's party, and over the next couple of weeks, the fluid just came back. And it came back sort of quicker than I ever expected. I'd weigh myself every couple of days, and my weight would go up by a kilo almost every day. And within 2-3 weeks, I was back to where I started. And it was only at that point mentally that I was able to accept that this was the right thing to do. I knew it was right clinically, but mentally, that is the point where I really bought into the whole thing and was subsequently admitted to the Freeman on the 22nd of October 2014. What happened in the Freeman is the waiting there was essentially another story. But there I met Stephen. This is Stephen after having his heart transplant about 3 weeks earlier. But he was the first person I've met who has also had a Fontane's operation. And it shocked me. He was 24 years old and almost exactly half my age at the time. And all I could think about was that he's not had a life. All the things I had done since I was 24, he's not done. And he's not had the opportunity to. And it made me realise how lucky I had been. Well, I might have paid the price for surviving for 40 years and having to have a heart and liver transplant, and not just a heart. But I couldn't, it took me ages. I still can't quite over the fact that a lot of Fontane's patients, and I know other Fontane's patients since, who run into trouble at a much, much younger age. And I think that those people should be here speaking to you rather than me, in a way, because I think I've been lucky. I've been lucky to the people I've met, lucky where I work, lucky for the wife who cared for me and got me access to the cardiology department to sort out when I had arrhythmias. But it's people like Stephen who are younger and probably are more representative of the population of people with single ventricles. So on April the 29th, almost 4 years ago, I had a combined heart-liver transplant, and if you want the nitty-gritty, it's all there in black and white. I won't pretend to understand all of it, but it was me. And since we're in a surgical meeting, here's a picture of Asif. This is not because it's all gone wrong. This is after 12 hours of me being on bypass. And I find this picture intriguing. I mean, the picture of Asif reminds me of the famous picture of the Polish surgeon who had completed a transplant, and he sat there exhausted while his patient's still on the table. And I can't quite believe that that is me. I feel detached from that picture completely. I can't believe that's sort of my leg and all my blood on the floor, but there you go. So I got home after a rather long and protracted recovery, and here I am with my younger brother and my daughter. And, you know, my life has gone back to being what it was, back to what it was probably 20 years ago, and enjoying things without the worry of going into AF or being ill, and just enjoying life. That's the only way I can describe it. But one big difference, I now do a lot of exercise. I've probably done more exercise in the last 4 years, well, in the last 2 years after my transplant, than the previous 50 years put together. And it's, you know, something I enjoy, and enjoy doing it because I can. So I go to the gym once a week, I play badminton, I've entered the transplant games to play table tennis and badminton this year. And it's a remarkable thing. It's the only way I can use to describe it. So what have I learned from having congenital heart disease? I think firstly you should take pride in the things that you can do and not worry about what you can't do. And you need to find your niche in life, whatever it happens to be. You do need to look after yourself, and I would pay thanks to my parents for how I was brought up, because they taught me that importance, and to my wife for, in my adult years, for making sure that I did all the right things. You do need access to high-quality specialised healthcare. Again, something I was lucky to have almost at my fingertips. And you have to trust the doctors and, I think, remain positive as you can, and really don't worry about things you can't change. You need the support of your family and your friends, and above all, which I think I've had in abundance, you do need a bit of good luck. So some people might say I have to thank the angels, but I would like to thank the 3 hospitals for which have cared for me throughout my life. And I thank you for your attention. Thank you very much. Yeah.
Thank you, Adrian. That was inspiring. We're very, very lucky to have somebody like you here today. And it's great to see a packed hall to listen to that story. We've got time for a few questions. So, Adrian, if you could just stay. And there should be some roving microphones. So if anybody wants to ask Joe or Adrian some questions, stand up, put your hands up. Or if not, I'm sure they'll be around after the session. But again, thank you very much. Thank you to Adrian, thank you to Joe.
There are plenty of seats at the front for those who are standing at the back if you want to sit down and rest your legs.
Good afternoon, everyone. It is a real privilege to stand here and to do the introduction for the Lifetime Achievement Award for one of our most eminent congenital cardiac surgeons, Professor Mark de Waal. He is here today together with his wife and one of his daughters, And I will take this opportunity to briefly go over his career and make it clear to you why he absolutely is a fantastic candidate for this award. Mark was born in Belgium and near Liège, and went to medical school and then did 3 years of surgery. And it was a very exciting time because the heart-lung bypass machine had just been invented and it became possible to do intracardiac surgery. Also, the first heart transplant had been done in South Africa, and Mark decided that he wanted to become a cardiac surgeon. There was no surgical training in Belgium, so he went to Stanford and did surgery there under Gebode, who is one of the leaders at that time. Following then that, he came to England, to Great Ormond Street Hospital, where he did a year as a senior registrar at Great Ormond Street, and then received a traveling fellowship via the AATS, which allowed him to visit the Mayo Clinic, where he went and spent another year and worked under the guidance of Wallace Magoon and Danielson, who were the movers and shakers in the congenital cardiac field. He then returned to Great Ormond Street, where he was appointed consultant and joined Jade Stark, the other surgeon in practice. He remained during his surgical career at Great Ormond Street until he retired from the NHS in 2006. There are quite a number of achievements from his surgical practice, but probably the most important of these are his interest in the development and refinement of surgical procedures for patients with single ventricles. In single ventricle circulations, there is essentially one pumping chamber, and this pumping chamber serves both the lungs and the body, and quite often there is a lack of blood flow to the lungs. So one of the advances that Mark made is to use a Gore-Tex shunt between the subclavian artery and the pulmonary artery that allowed a much more controlled blood flow for the augmentation of the blood flow to the lungs. He also contributed to the further development of the Fontan circulation. So when these patients grow older, the shunts are generally too small, and ultimately, when the pulmonary artery pressure is down, it is possible to connect the superior vena cava and the inferior vena cava directly to the lungs and leave the systemic ventricle to serve the systemic circulation. And the technicalities of this procedure have evolved over time, and in no means that was also due to Mark's efforts contributing to the understanding of the blood flow and the working conditions of the heart. Another major achievement was in 1988 when he introduced the program of heart and lung transplantation at Great Ormond Street. And 20 years later, now more than 500 heart and lung transplants have been done there. But having excelled in a surgical career, his achievements as an academic surgeon are even more impressive. Even before we were talking about translational research, Mark had a great interest in basic science and in collaboration, and he used specialists in basic science to form strong collaborations, allowing bench-to-bedside research. He's had a very fruitful academic career, more than 350 publications, many of those in high-impact journals, more than 75 chapters in books, and a co-editor of a surgical textbook that is now in its 3rd edition. His academic achievements have been recognized, and amongst the many awards he has had was that in 1998 he became professor of cardiac surgery at the University of London, and he is one of the only surgeons to achieve the Scientific Achievement Award from the AATS in 2011. There are 2 aspects of his research I want to talk a little bit more about, because these are actually currently hot topics and affect all our practice. The first one is that of computational fluid dynamics. There's been a long-standing collaboration between Mark and the Politecnica Milano, where basic scientists looked at mathematical modeling of flow. This has been used to look at the way how blood flow goes to blood vessels, how we deal with turbulence, and how loss of energy can be minimized. And this was one of the work that actually was also feeding in the ongoing modification for the Fontan circulations. Another piece of work that we all now know about, but probably do not know actually where this started. And it was Mark who recognized that surgical outcomes are not just guided by the patient and the risk factors, or by the ability of the surgeon, but also by the role of the team and how this team operates in a complex environment. And in the late 90s, he carried out a prospective observational study and convinced all then 15 congenital cardiac units in the UK to collaborate. And during this study, professional human factors observers tracked a patient that underwent an arterial switch operation from the moment that anesthesia started to when the patient ultimately arrived in the intensive care unit. Some of the findings are not surprising in that if there is a major error, then clearly this will affect patient outcome. However, if there is a major error and this is recognized, then the risk for death is actually not very high. But a very important finding was that there are actually an awful lot of very small errors, minor errors, that we either do not see or disregard. But the cumulative effect of all these minor errors do have a major impact and can have a major impact on outcome. So further research then looked at how do we deal with these minor errors, and from that the work with the aviation industry started, where people do have an anticipation of the minor errors and learn how to deal with it. Also, work started with Formula 1, where in the pit stop, which is a major component of the ultimate result of the race, people are actively looking for minor errors. And obviously, we need to know and find out how we can find these errors and how we can deal with it. And this has now become a major element of medicine today. Mark also was a very successful teacher, trainer, and mentor. And over the years, many overseas fellows came through Great Ormond Street Hospital, and many of those now have leading roles in the congenital cardiac world. In 1999, the UK National Congenital Cardiac Training Program started. And quite recently, the AATS started a Mark de Val traveling fellowship to give young budding surgeons the opportunity to travel to the UK or Europe to continue to benefit from having a period of observation or training in another center. I already talked about his textbook that he initially wrote together with Jade Stark and later was updated by Victor Sang for the surgery for congenital heart defects. And this book remains one of the mainstays for surgical training. Mark also once mentioned the qualities that you need as a surgeon. And one of the most important ones is passion, which ranks higher than technical skills, although these obviously are also very important. But also mental skills, because as a surgeon, you get exposed to the highs, but also the very lows. And sometimes patients, and particularly children, die. And you have to be able to deal with this. And obviously, he has worked very hard, but there also has been, in the background, a family. And for many years, he's been married to Vicky, who is here with him today. He has 2 daughters and also has 3 grandchildren. And I remember that when the grandchildren were born, and when he was still very busy at the US, it was very difficult to get hold of Mark, except when a grandchild came, and then everything just stopped. And the child came in and was allowed to play, to draw, until it wanted to go. Since he finished his work for the NHS, he's also had more time to take part in humanitarian work. And he's done it with Alessandro Frigiola, a long-term friend and colleague, and also currently is still the vice president of the Chain of Hope organization, which was started by Mark Yacoub in the UK. So Mark, I've given an overview of how you were as a surgeon, a scientist, a trainer, and a family man. And we very much would like to bestow this Lifetime Achievement Award on you. It's the society, but actually I was last week operating abroad, and I met one of your
Hey Mark, greetings from Aswan, from Karen and myself and everybody here. We've heard that you are, Karen told us that you are being honored, and my God, we are delighted and very proud because you have inspired so many people, including myself, of course, and nobody I can think of deserves to be honored than you.
So Mark, we really thank you for setting an example for us, for the pursuit of excellence, for your passion, your vision, dedication, for being a teacher, a scientist, an innovator, being humble, and being a mentor. And I hope you will accept this award given to you by the SCTS. Thank you.
Thank you, Karen. Mr. Chairman, ladies and gentlemen. Firstly, I would like to apologize for my dress code today. My granddaughter said, she put it at the end of this paper, I lost Mike Tyson 18-1. I am greatly honored and humbled to receive this award. Of course, I will accept it with a lot of gratitude. I'm honored and humbled to receive this award. And I would like to express my gratitude to all those who contributed to my achievements. First of all, the many patients and their families I have been entrusted to help in what often is the most trying experience of their life. This is the greatest privilege of our profession. Next, the nursing staff, for their dedication and the quality of their caring, which includes expanding responsibilities, many junior and skills. The nursing profession has changed over my career, which is 35 years, and the work they do, the responsibility they take, has increased tremendously, and I think we should work very hard to make sure that the work is respected and rewarded. I have enjoyed my association with many junior doctors. Very often, I learn more than I thought. By and large, however, I kept telling my juniors that I am in a superior position because I have made more errors than they do. To build a cult of error should contribute to excellence and must be part of the curriculum. It has been a privilege to be actively involved in the astounding progress in the research in the management of congenital heart defects. As it is often the case, scientific progress is the result of multidisciplinary acquisition of new knowledge. The treatment of hearts with a single ventricle can be an example, and Karen has shown the example a few minutes ago. I think the Fontan operation or circulation is the end result of the progress made 30 years ago. And I would mention 3 names, for example. The Aldo Casaneda, I think, has to be rewarded for the decision he made many years ago to treat the congenital heart defects as soon as possible. It's a disease we are born with, and they should be treated as they come, regardless of the age. And this is what has allowed the Boston group to start a program of Norwood operations. The other person would be Norwood as well, who has demonstrated that he could use the left ventricle, the right ventricle as a systemic ventricle, and to use the single ventricle with a reconstructed aortic arch so as to complete the replacement of the right side, which is draining by gravity rather than pumping activities. The last, I want to thank you, my family. I'm pleased that my wife and my older daughter are here today, and I have received an unreserved support and many sacrifices imposed on them by my profession, which too often came before the family and before the Porsches. Thank you.
Well, thank you, Mark. It's an absolute pleasure to be the president of this society at the time of Mark de Laval's Lifetime Achievement Award. I first heard the name de Laval when I started in cardiothoracic surgery in the 1980s, and that's when Great Ormond Street and Mark de Laval were making their mark on congenital heart disease. It makes me very proud to be here today with you. I'm sure it makes you very proud to be here to see the state of congenital heart surgery in the UK, as you've seen from the speakers that we've had, and the words that Karen says about you. It's meant from the heartfelt from everybody here. So thank you very much for coming today. I know it's been difficult because of the fall that you've had, but here is a token of our appreciation. It's a certificate with our signatures, and there's something very heavy in there, which I hope you will appreciate as a memento of today. So thank you, Mark.
Thank you very much.
Okay, so thank you everybody. That's been a great session. Before we close it, just a word of congratulations to David Barron, my co-chair today. I think everybody knows he's leaving the UK to go and work in Toronto. He's going to leave a big hole in congenital cardiac surgery. I meant the term literally, not with a congenital hole in the heart sort of thing. But we wish him well. So thanks to David for everything he's done today. It's lunchtime.